MedDRA coding. My name is Suzanne Sur Shaker or Shaker. Both pronunciations are correct. I'll be your instructor for this webinar. And joining me is my colleague, Hannah Eaton. Hannah is an MSSO training coordinator, and she kindly will facilitate our session for today. So starting off with introductions, I am a medical officer with the MSSO. Prior to that, I've had about 20 years experience in the industry, mostly in clinical research, and I'm based in New Jersey on the East Coast of the United States. So this webinar involves many interactive polls where you will use the Poll Everywhere tool as we go through some coding principles, and then we'll have a dedicated session for hands-on exercises in the second half. So at this time, I invite you to please access the Poll EV using the link as shown or the QR code on the screen. And we can start with a few questions to give you the chance to test the tool and to get to know you a little better. All right, so starting off with where are you joining from today? This will give you the chance to test out the tool as well, and we will use it heavily throughout the webinar. So it's always exciting to see the pins as they start appearing on the map. All right, and just as a reminder, the webinar is scheduled for 2 hours, is focused on advanced MedDRA coding, but it usually follows the basics webinar. So if you haven't had the chance yet to attend that one, please feel free to look up the next session offered at your convenience. All right, this is wonderful. I see many folks have been accessing the tool, but for interest of time, we will keep moving on. So welcome everyone. Thank you for giving us time of your day today, whether it's early in the day or late in the day for you. Thank you so much for joining us. All right, what primary role or roles do you perform? You can select as many as apply to you, whether in this life or in previous lives. It also gives us a chance to see how MedDRA is a tool that can be used by different teams, different groups, different professionals. So again, the majority are in pharmacovigilance or drug device safety. This is typical for our webinars, but I do appreciate everybody else who has joined us today. All right, and the next question is, how experienced are you with MedDRA? We do expect a certain kind of familiarity with MedDRA because we will be presenting advanced principles of coding. If you feel that you do want to attend a basic coding webinar, we do offer them on our website as well. So, all right, so thank you all for joining. All right, as many of you know, MedDRA was created in the 1990s under the auspices of the ICH. In fact, MedDRA is an ICH M1 standard. It's a multidisciplinary standard, and it is created by the ICH, but it is maintained by the MSSO, our team. The activities of the MSSO are overseen by the ICH MedDRA Steering Committee, which is composed of different regulators from different regions of the world, in addition to representatives of the industry with WHO as observer. The next slide is our disclaimer and copyright notice. Sorry, skipped over it. So our disclaimer and copyright notice. Just as MedDRA is owned by the ICH, the slides we are presenting are also owned and copyright protected to the ICH. However, with the exception of the ICH and MedDRA logos, you are allowed and encouraged even to use the slides and incorporate them in other works, share them with your colleagues, as long as you acknowledge the copyright and as long as you don't make any changes. If you do make any adaptations or translations or changes, please demarcate them and clearly label them and avoid any inference that they were endorsed by the ICH. The second bullet point is that the presentation is presented as is without warranty of any kind. The third one doesn't really apply because we don't have third-party material in today's session. All right, so for today, we will go over some advanced principles for coding with MedDRA based on an ICH endorsed guide that we call MedDRA term selection, points to consider. We will discuss a few useful resources to you with the MedDRA concept descriptions. We'll show several examples for coding using these advanced principles, and we will have the Poll EV tool to test the understanding with some hands-on exercises, and wrap up with some coding pros and a Q&A session. So one of the important resources for anybody coding in MedDRA or reviewing coding in MedDRA is the MedDRA Term Selection Points to Consider document. This is an ICH-endorsed guide for MedDRA users. It provides advice for using MedDRA for both industry and regulatory purposes. And the objective, of course, as always, is accuracy and consistency in term selection. And it's titled MedDRA Term Selection because when you are coding in MedDRA, what you are doing is you are selecting a term at the LLT, the lowest level term in MedDRA, that best matches the verbatim or the natural language term or your source report that you are trying to code. We do recommend that you use this document as the basis when you're creating your own individual organization-specific coding conventions, because you want to be consistent with this approach. The ICH endorsed guide was created with input from regulators as well as industry representatives, so it is a very useful resource for you. This was developed by a working group of the ICH Management Committee. It is updated annually in March in step with the March release of MedDRA. It is available for free on the website, and it is available in different languages, as you see on the screen, but also as an abridged version or a condensed version in multiple other languages, both on the MedDRA website and the JMO website. The JMO is the Japanese Maintenance Organization. It is a sister organization of the MSSO responsible for maintenance of MedDRA in Japanese. And to give you an idea of what that document offers, it has a wealth of different scenarios that you run into when you're coding verbatims from different sources. So you see examples on the screen. It has sections for example, death, combination terms, age versus event, specificity, how to approach neoplasms and congenital terms, even more options on the next slide, for example, device-related terms or overdose and toxicity, or off-label use, misuse, abuse. So just to show you where to find that document, I'm going to take you to our website. So this is our homepage at meddra.org. There's more than one way to find the documents. There's a quick link, a set of quick links on the top right-hand corner, and one of them says PTC, which is points to consider. And if you click on that, it takes you to the page that has all the support documentation. So there's a blue banner that defaults open when you access it from the quick link. And the very first document on the top is the MedDRA Term Selection Points to Consider. So it's available in different formats. There's even a version of the document in red line options, so you can see what, if anything, changed from last release. There's also different ICH guidelines. There's a guideline for data retrieval and presentation. This has its own webinar if you're interested in use of MedDRA for data retrieval, analysis, and presentation. And there's a additional document called a companion document. And for those of you who are interested in topics that are related to medication errors or product use issues, this is a very useful resource. Also an ICH endorsed guide. There's a document for best practices. This has a lot of detailed information about versioning with MedDRA, if you're interested in that. And then the gray banners are MSSO specific documents. So these are not ICH created documents, but they're also useful information. So if you're interested in coding, there's an introductory guide to MedDRA. If you're interested in analysis or SMQs, there's the introductory guide for SMQs, and the distribution file is a bit of a techie file, so it's a bit of a technical file. So the first way to access the blue banner is through the quick link on the top right-hand corner. The second way to access the same documents is under the How to Use tab. So as a MedDRA user, a very useful tab for you is how to use MedDRA, and it has different options. One of them is the support documentation. If you click on that, it takes you back to the same exact page, but the blue banner is just not defaulted open. So I just wanted to show you where to get that document, because we will be talking a lot about the different principles within it today. So general principles, these are covered in more detail in the basic coding webinars. Starting with, when you're coding, you always select a lowest level term in MedDRA that best matches your verbatim, but only select current LLTs. Non-current LLTs remain in MedDRA, but they're not intended for use in coding. They're really there so that you have the resource available to you for legacy or conversion or historical purposes. When you are selecting the most appropriate current LLT, you want to select the one that best matches your verbatim with as many details as possible, because the LLTs are intended to be granular. They're intended to offer you details. They do get aggregated at the preferred term level at the PT, but the LLT is where you find the most details in MedDRA. So an example that you see on the screen is abscess on face. MedDRA does offer a standalone abscess, but that's not the full representation of what you received in your report if you received an abscess on the face. So when you're looking in the browser for the best matched LLT, you can put in abscess and you can go through all the different types of abscesses, or you can try to find specifically the abscess on the face by using the stem or part of the word. So if you look for the word face and you look for the word abscess in the browser, you probably won't find anything, because the LLT in MedDRA is facial abscess. So it's spelled a little bit differently than face. So one way to utilize the browser to the best ability is by using a part of the word. So if you use FAC instead of face, you'll be able to retrieve facial abscess in the browser. And we can move on to the next principle. When do you select more than one term? Now, this particular principle will also rely on your own data configuration standards within your organization. So many of the examples we will show you today will show you how to select as many LLTs as needed to reflect the entirety of the original source verbatim that you received, that you're trying to code. But how to apply those LLTs will really depend on the data configuration standards that you've applied in your organization. So some organizations will have a one-to-one correlation between verbatim and MedDRA LLT, and some organizations allow you to select as many as apply to your report. So as we go through the exercises, we will be showing you examples where more than one LLT is needed. So when do we need more than one LLT? If you select more than one LLT, you have to also think about whether or not you are losing specificity or not, and also whether or not you are impacting your counts of adverse events. So if you're selecting more than one LLT, just be mindful that if you have a single adverse event and you're coding that with more than one LLT, you may be causing redundant counts. But if you don't choose more than one LLT, you may be losing some of the specificity offered to you in your verbatim. So something to think about, especially when you're approaching adverse event coding. Whatever you decide to do, it's very important to fully document your approach. So hence the importance of having your own organization-specific coding guidelines, and of course be specific and be consistent in your approach when you're documenting. So an example of a term where you could opt to choose more than one LLT is a metastatic gingival cancer, because we do try to keep MedDRA limited. We don't want to overpopulate MedDRA. We're not going to have LLTs that offer a metastatic qualifier for every single type of cancer. But there is an LLT for metastatic carcinoma. So when you're faced with a term like metastatic gingival cancer, you do have the option to either select one single LLT and then say that the most important part of this concept is the fact that it's gingival, so the location of the cancer, or you can select an LLT saying that the most important part of this concept for you is the metastatic qualifier. So you can select an LLT for metastatic carcinoma, or you can say that both types of the information, both parts of the information are important to me, so I can select two LLTs. But if you select two LLTs and it's a single adverse event, then you are risking an additional count in your total counts of adverse events. So something to think about when you're making your decisions and approaches on how to approach the use of more than one LLT per report. Another principle that is also very useful is checking the hierarchy. So when you are selecting an LLT, the hierarchy in MedDRA is 5 levels. So it goes from lowest level term to preferred term to high level term, which is the LLT, to high level group term, which is the HLGT, and then the system organ class, which is the SOC. When you're selecting a term in MedDRA that matches your verbatim, you also want to take a look at the hierarchy in MedDRA to make sure that it makes sense to you and that you're not taking your data into an area in MedDRA that is not a match to your source verbatim. So for example, you want to code a report of low energy. The words low energy do not exist as an LLT in MedDRA, but you decide that you're going to select the code of worn out as an LLT, and just to make sure that it matches your source verbatim, you check the hierarchy for worn out, you find that the LLT goes to the preferred term of fatigue, and you're comfortable with that selection. I want to show you another example that I found also useful. So let me take you back to our website. And just to show you where to access the browser, real quick, there's more than one way to also access the browser, just like there's more than one way to access the documentation. So again, with the quick links up on top, you have the WBB, that's the web-based browser. If you click on that, it takes you to the login for the WBB. And we have provided you, like Hannah mentioned earlier, temporary credentials in the chat. You are welcome to use these temporary credentials or your own organization credentials if you'd like to click along with us. The second way to access the browsers, again, go back to that tab of how to use. Just like we said, when you're a MedDRA user, one of the really useful tabs for you is how to use MedDRA. And if you go down to tools, here are the different tools that are available to you as a MedDRA user. And here's the button for the browsers. If you click on the browsers, you have the option to either open the web-based browser, takes you back to the same login that we just showed you, or the new web-based browser. So we have released a new web-based browser that has a simpler interface option for the users. It has the same features as the current web-based browser. You can also access the mobile browser, and you can download the desktop browser if you'd like. But let's start off with the web-based browser and log in. And just a quick outline, the panel all the way on the top, that's your tools and your settings. Your middle panel here is your search. The left one is your browser. That's all your system organ classes, all 27 of them. And of course, you are able to search in different ways. But we wanted to show you the example of tracing the hierarchy when you're picking out an LLT. So we're going to put a word here, and let's put the word cervical and just hit enter or click search. You can do that as well. So when you're looking for an LLT for a report that has the word cervical, cervical could have multiple meanings in the medical world. It can relate to something that has to do with the cervix, or it can relate to something that has to do with the neck. And if you pick an LLT, you need to make sure that you're picking the one that matches your source verbatim. So here's an example of acute cervical pain. To check the hierarchy for acute cervical pain, there's also more than one way. It has a plus next to it as an LLT. If I click on that plus sign, I'm going up in the hierarchy to the PT level, and then to the HLT level, and then to the HLGT level, and then to the system organ class. And I can see when I chose the preferred term, when I picked up the next level in the hierarchy, I can see that the acute cervical pain relates to the neck. So I can't use it if my reported source verbatim is talking about the cervix. But if I choose, for example, cervical abrasion, and I do the same thing, and I go up with the LLT to the PT through the plus signs, I'll see that there's more than one HLT. That's because this is a multi-axial term. And I'll see that it goes into cervix disorders as one HLT and reproductive system and breast injuries as the second HLT. So this is, in fact, is a term that relates to the cervix. So we said one way to check the hierarchy is by going up the pluses. A second way to check the hierarchy is I simply click on the term. If I left click on neck pain, this panel on the right just opened up with all the details of this particular term that I clicked on. So it shows me not only the hierarchy, here's the hierarchy with the PT, HLT, all the way to the SOC. It also tells me if this particular term is included in MedDRA in any SMQs, which is right here on the right-hand side. It also tells me a bit more details about this particular term, what level term this is, what the numeric code is, and the different hierarchy levels with their numeric codes for this particular term at the SOC level and at the SMQ level. So it gives me a lot of these details. There's a third way also to check the hierarchy for any particular term in MedDRA. This time I'm going to right-click instead of left-click. If I right-click this term, I get a pull-down option, and I can choose one of the options on here. I'm going to choose Go to Browser, the second one from the top. If I choose Go to Browser, it's going to take me to where this particular term is within the browser, within the SOC level here. So I can see it right here under neck pain, and I can see on the top here the hierarchy of this particular term. So there's my neck pain, I can see the HLT, the HLGT, and the system organ class. This is useful for me in certain areas like this, going to the browser. If I found a term that is close to my source verbatim, but maybe not the best match, and I was wondering maybe there's something better. So if I go to the browser and I check the areas around it, I can see similar terms to it that are associated with this particular term. If I expand the PT, if I'm at the PT level and I expand the PT, it will show me all the LLTs that are under it. And maybe one of them is the closer one to the wording of my source verbatim. They're all sibling LLTs, meaning that they all show up under the same preferred term. And the preferred term is the level of MedDRA that I use in my outputs, in my reporting, and in my analysis. So these are all getting aggregated under the PT neck pain. All right, so let me take you back to the slides and just move on with the general principles. But if you have any questions about anything we show you, please reach out to Hannah in the chat and she'll share them with me. All right, another resource that is useful to you when you are coding is concept descriptions. Now, MedDRA is not a typical dictionary in terms of definitions, but it does have descriptions, maybe for a limited number of terms within MedDRA. So concept descriptions are descriptions of how a particular concept is interpreted for the purposes of use in MedDRA, how it's interpreted for the purpose of classification in MedDRA. So this is not a definition of the concept, but a description to aid you in assessing how it's being used. This will help you be more accurate and consistent when you are applying these concepts in MedDRA. And of course, because different areas in the world have different approaches in medical practice, so some things may differ. I will also show you how to find these concept descriptions in the browser. This is a picture of how they show in the browser, but let me take you back to the web-based browser. So let me restore my default settings. This is how it's going to look like when you go in. We said the panel all the way on the top is your tools and your settings. One of your tools is your concept descriptions. It's the first blue button as you go through this panel. So if I click on concept descriptions, it opens up this screen. and I will see these alphabets. So they are alphabetized. They are sorted by alphabets. There are a limited number of concepts. It's not, of course, feasible to give a description of all the thousands of terms that are in MedDRA, but some concepts in MedDRA are worthwhile describing to make it clear how they are being used and interpreted for purposes of MedDRA coding. So, for example, let's go to M and let's show you misuse. So misuse may be a concept that is not approached the same way in different regions of the world, but misuse for the purposes of MedDRA needs to be standardized. So the concept description will tell you that misuse for the purposes of MedDRA is intentional. So first of all, it's an intentional use of a therapeutic purpose. So it's misusing a therapeutic product for a therapeutic purpose intentionally, and this is done either by a patient or by a consumer of a product. And of course, the use is different than as prescribed or in accordance with the authorized product information. So this is an example of how MedDRA gives you concept descriptions to assist you being consistent and accurate in your coding. You see also here, for example, overdose. So overdose also may be defined a little bit differently in different regions of the world or different organizations, but MedDRA needed to be standard in its application of overdose, and overdose for the purposes of MedDRA selection is more than the maximum recommended dose. So that's another example of how to use concept descriptions. And just to show you where to find these concept descriptions in your new web-based browser, if we go back to how to use tools, browsers, and open up the new web-based browser. So this is the new web-based browser. You can use the same login credentials for the new web-based browser, but to find the concept descriptions, as you can see, this interface is much more simplified because it's focused on the research function. Of course, you can convert this to the same display as the legacy browser if you like. You can use that. So you have these settings, and the settings will allow you to show everything if you like to see that. Under documentation, if you select documentation, here's your concept description. So if I click that box, I see that right here, something new showed up. It looks like maybe a medical document with that plus sign on it. And if I click on it, here's my concept descriptions, the same exact concept descriptions that I accessed in my legacy browser. All right, so let's go back to the slides. Before we go to any advanced principles, any questions so far, Hannah?
I'm not seeing any questions yet in the chat. Oh, one just came in. Sorry, I spoke too soon. Okay. The question reads, MedDRA concept description mentions that a medication error is accidental. This means that if we detect an intentional deviation from the label in a prescription, it would not be a medication error, but either an off-label use term or suspected off-label use term. Will the concept descriptions be updated to add the concept of suspected off-label use?
So medication errors are not necessarily accidental. They are defined as unintentional. So unintentional meaning you didn't do it on purpose. Now, accidental, as a word is not always available in the different types of the medication errors, but a medication error is definitely unintentional. Off-label use, right here, off-label use is intentional. So the main difference between medication errors and other types of different uses of the product, whether you're thinking about misuse, abuse, off-label use, all of those are intentional. So they were done intentionally. Now, you are right that there is a suspected off-label use, and that is something new in the most recent release of the points to consider term selection. And I want to show you that paragraph. So I'm actually happy that you raised that question, but let me go back to our website And let me show you where that paragraph is. So again, how to use support documentation. We are interested in the blue banner, and here's my points to consider release for the MedDRA term selection. I'm going to show you the red line version. So if we go to the red line version, you can download the file. And when that file gets downloaded, this is what you're going to see. So you're going to see the red line version. And if I put in off-label, maybe it's not hyphenated, off-label. Okay, so here's my off-label use. All right, let me take you to that section. All right. So this was one of the areas that had I think, a significant change in the points to consider document in the most recent release in March. So off-label use and suspected off-label use, we did not used to have a suspected off-label use in previous versions. So in the scenarios where you were not sure that this was an off-label use because it wasn't mentioned in the verbatim, the recommendation at that time was to obtain clarification. And if clarification cannot be obtained, don't make the inference that this is off-label use. But now there is a new section for 327.3. So if you go down to 327.3, now it tells you there's something called a suspected off-label use. This may be selected when there is medical judgment to indicate that the product was used off-label, even though the words off-label are not stated in the reported verbatim. So the working group, that's combined of both representatives from regulatory as well as industry, did discuss this because this was a common question from MedDRA users. And they did agree that there is a need to add terms in MedDRA that speak to suspected off-label use for these kind of scenarios. So you have it now available to you in MedDRA as options for coding and in the PTC guideline with these instructions clarified and also an example given. Right, so a drug was prescribed for a 6-year-old child, but you have information that tells you this kind of treatment is accepted for pediatric patients as an off-label practice, and you have a rationale for suspecting that this is an off-label use, so you can choose that LLT that's newly added in MedDRA. Of course, that idea that you have this additional information is assumed here, that you can use that suspected off-label use, because if there is no medical knowledge about this drug being used in the pediatric population, and if there is no basis to suspect off-label use, then there is another option in MedDRA for drug prescribed for unapproved age group. So to go back to your question about the concept descriptions, let me just go back. Let me just take you back. So if we go back to the concept descriptions, and they were here. So to take you back to the concept descriptions and to off-label use, the main difference is the intentionality, that the off-label use is intentional. Medication errors are unintentional. And honestly, I'm not sure if they are intending to add suspected off-label use. I mean, if we go to the S, I don't think it was added, but let's double check. Yeah, I don't think it was added. I'm not sure they're planning on adding suspected off-label use because it's clarified in the points to consider document. If you think that it's helpful to add it in the concept description itself and you'd like to submit that as a request, please reach out to our help desk and we'll have it reviewed by the IMOs. Any other question, Hannah?
It looks like that was our last question.
Okay, All right, so let's discuss some advanced principles in MedDRA coding or MedDRA term selection. These are all part of that ICH endorsed guide of the PTC guideline that we just showed you. So, for more details, please reference that document. But let's give you examples of these advanced principles, starting with how to approach reports that have a single diagnosis when that diagnosis is definite versus provisional. And when we say provisional, it just means that the the report itself will have some kind of description telling you that it hasn't been confirmed. So examples of words like presumed or probable, suspicion of, rule out, questionable, differential, all of those are qualifiers that a reporter can use to show you that they haven't yet reached a final diagnosis. So the PTC document will tell you that if it's a definitive diagnosis and there's no signs and symptoms, the only option you have is to code the diagnosis. So if you have myocardial infarction, you select myocardial infarction. When you have a provisional diagnosis and there's no signs or symptoms, again, the only possible option is to code the provisional diagnosis. So if you have possible myocardial infarction, the only thing that you have received from the reporter is a possible myocardial infarction. So the only thing you can code is the myocardial infarction. That's when you don't have signs and symptoms. When you do have signs and symptoms, again, there is a preferred option in the PTC guideline and an alternative option. So that's an interesting thing also available in the PTC guideline, is that sometimes there's more than one way to code the term. And just because an option is listed in the PTC guideline as preferred, it's not mandatory that you follow the preferred option. Of course, you can follow the alternative option, but please document. Always document your organizational approach to these kind of scenarios. Ensure your team is trained so everybody is consistently following the same approach, because consistency is always key for good data analysis. Okay, so talking about the preferred option in these kind of scenarios, when you have a single diagnosis and it has signs and symptoms, and those signs and symptoms are all related to this diagnosis, the preferred option, according to the PTC guideline, is to only code the diagnosis. So, for example, you received a report, and the report said anaphylactic reaction. The patient had rash, dyspnea, so they were short of breath, their blood pressure dropped, so they had hypotension, and they had laryngospasm, which is when your throat closes up and you can't swallow, you can't breathe. All of these signs and symptoms are related to the anaphylactic reaction. So the preferred option in this case, according to the PTC guideline, is only code the anaphylactic reaction. You don't need LLTs for the rest of them. That's the preferred option. When you have a provisional diagnosis, so it's not confirmed, they're telling you they suspected this concept, but they also sent you the signs and symptoms. So, for example, they had a possible myocardial infarction with chest pain, again, the shortness of breath with the dyspnea and the diaphoresis, so they had sweating. The preferred approach, according to the PTC guideline, is to code everything, code the provisional diagnosis, and code all of the signs and symptoms. So you select LLTs for the myocardial infarction, as well as the chest pain, as well as the dyspnea, as well as the diaphoresis. And the rationale for that, for the PTC guideline, is that your provisional diagnosis may eventually change to something else, but your signs and symptoms will remain, because they are the signs and symptoms. You may come back and say, oh, we ruled out, we were sure that this was not myocardial infarction, this was something else, and they gave you a different diagnosis. So the provisional diagnosis may change, but the signs and symptoms do not. So this is the preferred approach according to the PTC guideline. But there is a different approach, an alternate approach. The alternate approach for a single diagnosis with signs and symptoms that match that diagnosis is to code everything. And many organizations actually choose that. They will code everything, even though it's a definite diagnosis with signs and symptoms that are consistent with that diagnosis. What about the provisional? If you had a provisional diagnosis with signs and symptoms, the alternate approach is only code the signs and symptoms. Again, because the provisional diagnosis may change. So that's the alternate approach according to the PTC guideline. Your own organization can select which of these approaches suits it best, document that in your own organization coding guidelines, and ensure that everybody is trained and consistent in their coding approach. Of course, if you have signs and symptoms that are not related, Sorry, folks, my slides just froze. And let me take you back to where we were. All right. Can you see the slides, Hannah?
Yes, I'm seeing the diagnosis and provisional diagnosis continued slide.
Okay, thank you for that. All right, so if you have signs and symptoms that are not associated with the diagnosis, that's a scenario where you do need to assign LLTs to whatever sign or symptom that you receive that is not associated with that particular diagnosis, because this could be a whole new problem that the patient is complaining from. So for example, you received a report and the report said myocardial infarction, chest pain, dyspnea, diaphoresis, ECG changes, and jaundice. Out of the entire list, the one that doesn't make sense when it comes to myocardial infarction is the jaundice. It's not a typical sign or symptom associated with myocardial infarction. So if you are following the preferred approach per the PTC guideline where you just code the diagnosis, then you're coding myocardial infarction, but you also need to code jaundice because jaundice may be a separate medical occurrence that's happening to that patient. All right, let's start with our first hands-on exercise about what term to select. I'm going to activate this question, and you have the QR code on the screen as well. All right, and let me just make sure that this is also active. All right, it should be active. So I do see responses coming in. So let's practice what we just talked about. This is the report that you've received. It says there was a sepsis leading to shock from possible spontaneous bacterial peritonitis or bowel perforation. So the word of interest here is possible. That means it's provisional. So you're seeing a sepsis leading to shock. You're seeing the possible spontaneous bacterial peritonitis or bowel perforation. Applying the principle that we just mentioned, how would you code this? And just to save time, we are offering you LLTs. We will do this with all the exercises we show you. We'll offer you a group of LLTs. All you need to do is select. But of course, when you are coding on your own, you need to go to the browser and try to find the LLTs that best match the verbatim. But for interest of time, we will show you, like a multiple choice question, the LLTs that are that could be the right ones, and you just select them. All right, so I think we have enough number of responses. Let's click on the responses and see. What folks think. All right, so I see many folks have picked the septic shock because sepsis leading to shock, although there are LLTs separate for sepsis and for shock, but you have septic shock in MedDRA, so that captures both of them in one LLT. That's the better approach. So yes, septic shock. I do see folks have picked out options for spontaneous bacterial peritonitis and bowel perforation, not as many as folks who have picked out the septic shock. So let's see the correct answers here. The correct answer, based on the principle we just mentioned, is that if you have provisional diagnosis, then you need to code the provisional diagnosis in addition to signs and symptoms. Now, these were not truly signs or symptoms. This is an etiology. This was a septic shock that was a result of either possible spontaneous bacterial peritonitis or bowel perforation. So you have two provisional diagnoses that are offered to you, and you have an outcome of those two, one of those two provisional diagnoses. So the reporter was not sure which of these diagnoses is the one that is the definite. They gave you two provisional diagnoses. The correct approach is to code both of them. So for this particular report, the correct answer is to code the septic shock as well as the two provisional diagnoses. All right, let's move on to the next slide. The points to consider document also talks about how to approach conflicting or ambiguous information. So of course, when you have conflicting information, it means part of the report is telling you one thing, but the same report could be giving you a different information as well. Ambiguous information means it's not very clear. Now, if you're in clinical research, you have the ability to issue queries. Of course, you would issue a query to clarify if there's any ambiguity or conflict in the report you received. That's not always possible, though. So the PTC guideline does give you advice on how to approach conflicting or ambiguous information. Sorry, let me just take you back to the slide. All right, so if you are unable to receive or obtain more specific information and you have a conflict in the report. So the first example that you see on the screen is an example of conflict in the report. They gave you hyperkalemia with a serum potassium of 1.6 milliequivalents per liter. Now, for the potassium level in the blood, a 1.6 milliequivalent per liter is kind of low because the normal range usually tends to be maybe 3.5 or 3 point something to a bit of 5 or a little bit higher than 5 milliequivalent per liter. So that's definitely low. But the same reporter is telling you the patient had hyperkalemia with a serum potassium that is low. This is conflicting information. The same report has a conflict. You're not sure which part of the report is correct. So when you have this kind of report and you are unable to obtain more specific information that is clear from the reporter, then in this case, your best approach is to select an LLT that says that the serum potassium was abnormal. That way, you are not assuming that the first part is correct and you're not assuming that the second part is correct because there's a conflict. So in the PTC guidelines, they advise you that the best approach here is not to make an assumption, but just to say serum potassium was abnormal. The second example for the GU pain. Now, GU is an acronym, and there was an exercise in MedDRA to clean it of all ambiguous acronyms. So acronyms that are ambiguous are non-current in MedDRA because GU could stand for genitourinary or it could be gastric ulcer. If you are unable to get clarity from the reporter with additional information, then in this particular case, you know that there's pain, you just don't know where. So in this particular example, you can code pain. What about if the report is so vague that you really don't have anything to code, like you don't have pain? For example, turned green. Turned green is such a vague report that you don't know whether this is referring to the patient or to something else, maybe the pill turned green or the product or the liquid turned green. You're not sure what they're talking about. So MedDRA does have options to account for these kind of scenarios where you just don't know, but you have to assign an LLT. You can't leave it uncoded. So the best option in this case is unevaluable event. You know that there's something that happened because they reported it. You just don't know if it's related to the patient or not related to the patient. So because you cannot assume that there was a disorder that's being reported, you code an unevaluable event. If the report is vague, but at least you know that it's related to the patient, the second example on your screen, the patient had a medical problem, but we don't know, it's not a clear type of problem. We don't know exactly what it was, but we know that the patient complained of something or had a medical problem. We just don't know what it was. In this case, because we know that the patient was affected, we know there was a disorder, but we just don't know what it was. So the best option in that case is ill-defined disorder. And those are the approaches as per the PTC guideline. So let's try another example for clinical complication of IUD. How would you approach it? So if you have clinical complication of IUD, and the big question here is, how would we approach an IUD? Is this intrauterine device? So would this be a complication of the intrauterine device? Is this intrauterine death? So this is a complication of a fetal death. How would you approach this one? And I see some responses have come in. So let's click on responses and see what most folks think. Most folks have got it right because the IUD is an ambiguous acronym. The way that it's reported of a clinical complication of IUD in this context could be an intrauterine device. It could also be an intrauterine death. So the correct answer is unevaluable event. So thank you for choosing that. What about this example? Hypoglycemia with a blood glucose of 200 milligram per deciliter. Let's activate the poll. And let's see what most folks think. So this is hypoglycemia with a blood glucose of 200 milligram per deciliter. How would you approach this one? I do see responses coming in. So let's take a look at what most folks are thinking. Most folks are thinking again correctly. Yes, this is blood glucose abnormal. And the reason for that is this is a conflicting report. Hypoglycemia means that the blood glucose is low. It's a condition where the blood glucose is low. But the numeric qualifier that they provided actually indicates that the blood glucose is high, thus in milligrams per deciliter. So in milligrams per deciliter, a blood glucose of 200 is actually elevated. This is conflicting information. So based on the PTC guideline, your best approach is a blood glucose abnormal. So what about investigations when you receive a report as an investigation? So, and sometimes when you have, like just the example we mentioned with a numeric qualifier as well as a condition. So hypoglycemia in MedDRA goes to the disorder SOC. It is a disorder, so it goes under the metabolism and nutrition disorders. Decreased glucose is a finding. It's a investigation or a lab finding, so it goes to a different system organ class of investigations. Either one could have been reported as your adverse event. But if you are coding, you need to make sure that you are true to your source verbatim, whatever the reporter gave you. So if the reporter gave you hypoglycemia, you need to code it to a disorder of hypoglycemia. If the reporter gave you a decreased glucose, an investigation, you need to code it as an investigation. What about if the reporter gave you an investigation, but the result is ambiguous? So ambiguous again means it's not very clear. So if you had a glucose of 40 milligrams per deciliter, they're giving you a numeric qualifier, and they're giving you the actual what do you call them? The actual I'm sorry, I can't remember the word of the name, but the actual type of numeric results. So it's in milligram per deciliter. But glucose worldwide is not just reported in milligrams per deciliter. There's other types to report glucose, like, for example, millimoles per deciliter. So when you have it clearly provided to you as 40 milligrams per deciliter, this is clearly below the reference range. So glucose is low. But if the only thing they gave you was that glucose was 40, and you don't know if this was milligrams per deciliter or millimoles per deciliter, that's very different. Because in milligrams per deciliter, depending on whether or not your range is for diabetics or non-diabetics, You could go from 70 to 99 milligrams per deciliter, or from 90 to 130 milligrams per deciliter as your normal range. But if your result is in millimole per deciliter and you have 40, that's actually very high. So if you don't have enough information to ascertain whether this is within normal range or not within normal range, then again, your best option is to say glucose was abnormal, because you don't have enough in your report to ascertain whether this is above or below the normal range. So I hope that that was clear. There is another scenario where you have both a condition as well as the numeric result in the same report. So how would you handle this? This would be handled very similarly to a diagnosis with signs and symptoms. If you have elevated potassium and they gave you the numeric result of 7 millimole per liter, which matches the elevated potassium, and they gave you hyperkalemia, all in the same report, then the best approach here is to code the hyperkalemia, because that's a diagnosis where you have elevated potassium for that particular diagnosis, and capturing that hyperkalemia takes you to the disorder SOX. So it's not necessary to select a second LLT for the potassium increased. It's part and parcel of the diagnosis of hyperkalemia. Sometimes your report may give you more than one result or more than one investigation. So for example, they gave you a report that says there were different labs increased, including alkaline phosphatase, the SGPT, the SGOT, and the LDH. They were all elevated. Although MedDRA does offer LLTs that say, for example, liver function test abnormal, that is not the best approach per the PTC guideline. Per the PTC guideline, the recommendation here is to split these up and code each one separately. So you want to capture the fact that there was alkaline phosphatase increased, as well as SGPT increased, SGOT increased, and LDH increased. The rationale is that they did not give you a diagnosis for all of these labs, and they could all be significant. So they could all be significant and they did not give you a diagnosis. If they had given you a diagnosis that matches all of these increased labs and it made sense to code only the diagnosis, you could do that. But when only elevated labs are what's reported, the recommendation is to split them up. Let's try it out with a hands-on exercise. Okay, here's a verbatim. Let me activate the poll. The poll says, or the question says, the testing showed increased serum creatinine and BUN and increased BUN creatinine ratio. So based on what we just explained, according to the PTC guideline, which of these would you select for this particular report? So the report said there was increased serum creatinine, increased BUN creatinine ratio. How would you approach this? So I have enough results. Let me just show responses. Okay, let me show responses here. And the responses are that we will code the increased serum creatinine, we will code the BUN increased, and we will also code the BUN creatinine ratio increase, and that is correct. It follows the principle that we just mentioned, where if you have multiple labs, you don't have a diagnosis, the recommendation is to code all of them. What about this one? Patient had features of aldosterone excess. What do you guys think of this one? This may be a little bit tricky, but I'm curious to see how people will think about this one. So the report that you received says the patient had features of aldosterone excess. What is it that you have received? Ask yourself, always ask yourself, what is it that you have received? Are you receiving a lab result? Are you receiving a diagnosis? Are you receiving a diagnosis with a lab result? And are they consistent with each other? So patient had features of aldosterone excess. I think I have enough responses. Let's see what folks are thinking about. Wow, this is this is very interesting. Across the board, so we have folks are coding the aldosterone increased, the blood aldosterone abnormal, and the aldosteronism. Let's see what the correct answer here is. And the reason for this. So why did we pick aldosteronism for this particular example? So the report is telling you something about the patient. The patient had features of aldosterone excess. So aldosterone increased in this patient. Yes, it is increased, but there is a diagnosis here because they had features of this. You won't have features of aldosterone excess unless you had the diagnosis of aldosteronism. It's not just a lab finding. And it's not really the conflicting information. So there's no reason for the blood aldosterone abnormal because there's no conflicting information in this report. It's giving you the fact that the patient had features of aldosterone excess. So this is a report about a medical condition in a patient. So you should code the medical condition, not just the single lab finding. So I know that this was a tricky example, but please, it's just a way to get you thinking about the reports moving forward. If you are receiving something that reports a medical condition with lab results and they are consistent with each other, you do need to code the medical condition or the diagnosis. What happens if you are receiving combination terms, more than one information in the same concept? So a combination term in MedDRA, it's a single medical concept. It's combined with additional medical wording that either provides information about pathophysiology or, for example, etiology. Combination terms are not that common in MedDRA because they do need to be internationally recognized. They need to be distinct and robust as medical concepts to be admitted into MedDRA. But here's an example for what to do in this case. If you received a condition that seems to be a combination term, you need to ask yourself, are they reporting the same thing? So arrhythmia due to atrial fibrillation. Every single atrial fibrillation is an arrhythmia. So when they tell you arrhythmia due to atrial fibrillation, it's really, this is one medical concept of atrial fibrillation. Why would you add a second entry of arrhythmia and add the counts, on your total AEs when in fact there was a single incidence of atrial fibrillation? So when it's atrial fibrillation due to arrhythmia due to atrial fibrillation, there's really no need here to split because every single atrial fibrillation is an arrhythmia. Same for hepatic function disorder defined as acute hepatitis or clarified as acute hepatitis. Acute hepatitis itself is a hepatic function disorder. So you're coding only the acute hepatitis. But combination terms exist, for example, like retinopathy due to diabetes. So yes, you have diabetes and you have retinopathy. You can look in MedDRA to see first whether a combination exists for these two concepts, and you'll find diabetic retinopathy because diabetic retinopathy is internationally recognized, it is distinct, it is a robust medical concept, so it does exist as a combination in MedDRA as a diabetic retinopathy. Same for itchy rash, same for HER2 positive breast cancer. So you don't need to split in those cases, but not every type of rash is available as a combination term in MedDRA. Not every type of cancer with the underlying subtype is available as a combination in MedDRA. So when you have a combination term, you can take a look to see if that exists in MedDRA. And if not, like the next slide, if you don't have a combination term, you do need to split. So diarrhea and vomiting are two separate medical concepts. There's no diagnosis in this report, so you do need to capture the diarrhea and the vomiting separately. This will give you more clinical information. Risk factor due to fall are two separate concepts, and the fall itself is important to capture because the fall may have resulted from your product. Your product may have caused the patient dizziness and they fell. So it's important to capture the fall, and if you're able to elicit from the reporter what caused the fall, that's even more clinical information that you'll be able to capture. The BRAF positive malignant melanoma, that kind of gene mutation is not available as a combination term for melanoma in MedDRA. So you do need to split them up, because for example, in oncology, there may be situations where it's important to capture the information not only for the tumor type, but also for the associated genetic marker or genetic abnormality, because there could be implications for etiology or prognosis or treatment. So let's practice. Here is a report. The patient had retinal disease from HIV with near total blindness, both right and left. How would you approach this particular report? What do you guys think about this one? I see the responses starting to come in. Okay, so you want to ask yourself, how much information am I receiving here? Is there a combination term available that I can use? And what to make sure I don't omit from my report. Okay, so I have enough numbers. Let's check responses. All right, so a lot of folks picked the HIV retinopathy because that captures the fact that there was retinal disease, and this retinal disease was from HIV. So just like diabetic retinopathy, MedDRA has a combination for HIV retinopathy. I'm also happy to see many folks are picking an LLC for blindness, both eyes. Those are the correct options. And the reason for that is HIV retinopathy does not typically cause blindness. In fact, many cases for HIV retinopathy are mild or asymptomatic. So it can lead to vision impairment if complications arise. So I am glad to see this. And this also kind of showcases that you may need to research sometimes when you're looking at reports to clarify whether or not a result from a particular medical concept is expected, a sign or symptom is expected. If it's not expected, then it's worthwhile capturing that, because there could be something else. There could be another pathology going on with this particular patient that needs to be identified. All right, our next section, it touches on medication errors. So we showed you the concept descriptions of medication errors. Per the concept descriptions, medication errors are unintentional. They are also preventable. And the reason that many regulators have a huge interest in medication errors and coding of medication errors is the fact that they are preventable. So there could be action that can be taken to avoid patient harm, decrease patient harm, and so on. So the medication errors, the approach in MedDRA, they are concepts that are unintentional and they are preventable. They may cause or lead to inappropriate medication use or patient harm while the medication is in the control either of the healthcare professional, the patient, or the consumer. The PTC guidelines has a section dedicated to medication errors because it's such an important topic, but we'll give you a few of the approaches in the PTC guideline. If you have a report that gives you a medication error with clinical consequences, the approach per the PTC guideline is to capture both the medication error as well as the clinical consequence. So the patient was administered a wrong drug, and that patient experienced hypotension. When you have this kind of report, it's very important to capture the fact that a wrong drug was administered, that's a medication error, and that there was a clinical sequence, a clinical sequelae, which is the hypotension. Sometimes you have reports where a medication error occurred, but there was no reported clinical consequence. So for example, an intramuscular formulation medication, it was given IV instead of IM, but the patient did not experience any adverse effect. There's more than one way to code this according to the PTC guideline. The preferred option in this case is only code what happened. And what happened was the medication error. So an IM formulation was administered by another route. There is a second option for those who are interested, which is not only code the medication error, but you can also code the fact that there was no adverse effect. but this is a negative. So it's really something that you have to discuss internally as an organizational approach. Do you want to capture a negative as part of your AE coding? Do you want to capture the fact there was no adverse effect? Or are you interested in capturing the fact that there was no adverse effect? Because some organizations, so think, for example, poison centers, if they are exposed to a poisonous product, but nothing happened, it's very important as part of their protocol or their approach to capture that fact. But if you're coding adverse events in a clinical trial setting, you don't want to capture the fact that there was no adverse effect. That's a negative. So it depends on your scenario, it depends on your organization, but according to the PTC guideline, the preferred option is only capture the medication error if there's no clinical consequence. Now, if there is potential for a medication error to have occurred, but it didn't occur. So, for example, the pharmacist noticed names of two drugs, they look similar. The pharmacist was concerned that this may result in someone getting a wrong drug. So nothing really happened here, right? Nothing happened. There was no medication error, but there was a scenario where a medication error could have happened. In this particular kind of scenario, the PTC guideline does stress the fact that it's important to capture the potential for the medication error, even though it didn't happen, as well as the contributing factor. What could have led to this medication error? So even though this is something that didn't happen, the PTC guideline stresses the recommendation to capture both the contributing factor, which is the fact that the drug name looked alike, that's an LLT in MedDRA, as well as the potential for the medication error of wrong drug. The regulators are really interested in these kind of scenarios because this is where the intervention can be very successful at preventing patient harm before patient harm occurs. So the reason why they are capturing the potential for medication error occurring in addition to the contributing factor is to introduce actions that can prevent patient harm before patient harm occurs. So this is why they are interested in the potential for medication errors. And like we said, medication errors are a very important topic. It has a lot of resources available to you. The PTC guideline has a section dedicated to medication errors, accidental exposures, and occupational exposures. And that additional companion document that I showed you under the blue banner is full of information, very detailed information about medication errors. And there is a high-level group term in MedDRA, an HLGT for medication errors and other product use errors. Let me show you where that is. All right, so let's go back to, okay, let me go take you back to the WBB. If you're not sure how to find that HLGT, that high-level group term, you can just put in medication error and hit enter or hit search. And the default outputs and your search results will give you the different levels of MedDRA that have medication error. So you have your LLT that defaults open, you have your PT, HLT, and your HLGT. So here's your medication errors and other product use errors. If I right-click it, like I showed you before, if you right-click and go to browser, you'll see that HLGT in the middle of the MedDRA hierarchy right here. And if I hit open, that plus sign next to it, I'll see all the HLTs under it. And you'll notice that the outline or the way that they are presented for medication errors is dependent on the scenario of that medication errors. So if they could be administration errors where the patient ended up taking the wrong drug, could be product confusion errors where the product has something that makes it confusing. Maybe the label is confusing, the name is confusing. There could be dispensing errors, monitoring errors, preparation errors, prescribing errors, or selection errors, storage errors, transcribing errors. So depending on your scenario. So when you receive a report for a medication error, and you can at least tell what cycle, which part of the medication use cycle this occurred in, and you decide this was an administration error. You can look through all the PTs available to decide which one of these best matches the scenario. So for medication errors, really, it's useful to start off with the larger grouping terms and then drill down to the PTs and then even the LLTs. So if you decided that an incorrect dose was administered, you can see all the LLTs under it and see which one of these is the best match for your scenario. And we do talk about this in more detail in the webinar dedicated to medication errors. So let me take you back to the slides. So we said that the concept descriptions in MedDRA also have descriptions about medication errors and medication use scenarios that you can reference so that you know how MedDRA approaches certain types of medication use scenarios. And of course, we said we have a webinar dedicated to MedDRA coding of medication errors. We also have the learning management system modules specific to these kind of scenarios under special situations. And we have videos on our YouTube channel that talk about medication errors. So all of these are resources available to you. All right, when we talk about overdose, toxicity, and poisoning, we said overdose as defined per the concept descriptions for the purposes of MedDRA coding is that the dose is over the recommended dose according to the official documentation for that particular product. So overdose could happen with clinical consequence or without clinical consequence, just like medication errors. If you have a report for an overdose with clinical consequence, the recommendation, you may have guessed it by now, is to capture both. You capture the overdose and you capture the clinical consequence. If you have a report without clinical consequence, you have more than one option. The preferred option is to capture just the overdose, but you do have an alternate option according to your own organizational approach, according to your own preferences, as long as it's documented, to capture both. The fact that an overdose happened and there was no adverse effect. But just again, as a reminder, if you follow an approach in coding that is not the same as the preferred option in the PTC guideline, that's perfectly fine. Just please make sure it gets documented, trained to everybody in your team who's going to be coding, and quality assured for consistency. So let's try it out. Here's an example. Let me activate the poll. All right, so this is an example where a syringe plunger couldn't be completely pushed down. So this is a report you received. It's telling you the story of what happened. The syringe plunger couldn't be completely pushed down, and the patient ended up receiving half of his scheduled dose. How would you approach this kind of report? So these are the LLTs that we selected as the multiple choice question. Which of these, maybe more than one, would you select to reflect the information you received from the reporter? All right, so I have close to 50 responses. Maybe this is a good number to show the responses here. What do folks think? Okay, so one of the LLTs say that the patient received a partial dose. This was by the device. This is very nice, and this shows you also an example of how detailed some of these LLTs in MedDRA are. So the word partial is not in your verbatim, but this is what happened. The patient received half of their scheduled dose because of the syringe plunger not being pushed down completely. Now, is there something else that this report also gave you? So yes, the patient only received a partial dose. It's not horribly wrong that the wrong dose was administered, but the fact that it was partial by the device is more specific to the scenario. So the folks who selected wrong dose administered, it's not that this is a completely wrong LLT. It's just that there is an LLT that is a better match to the detail of the story that you received. But what else did this story tell you? The syringe plunger couldn't be completely pushed down. There's something going on with the device itself. And you do want to capture that, because at the end of your data capture, when you're running your data analysis, if this was a one-time off, that maybe that one product was impacted. But if this was a recurring LLT and you see a lot of them, then maybe this is a manufacturing issue, and you want to go back to your manufacturer and discuss what's happening with this particular plunger. Why are so many reports coming in with this particular syringe not working as expected? So you do want to capture as many LLTs as you can, because at the end of the day, when you do your analysis, it will give you a clearer picture of your product that will be helpful to you for any future actions needed. Let's look at this example. Unintentionally took more than the maximum recommended dose due to a dispensing error. So what do you guys think of this one? All right, I'm starting to see the responses coming in. So the patient unintentionally took more than the maximum recommended dose. And we've heard that word maximum recommended dose before. So let's see what most folks are thinking. Most folks are thinking correctly. I'm very happy to see this. The correct answers in this case, you do want to capture the accidental overdose. So again, the folks who selected incorrect dose administered, it's true that the patient received an incorrect dose. It's not a wrong LLT, but it's not the most specific to this particular report. The reporter is telling you why they ended up taking the incorrect dose, which is there was an accidental overdose, and the reason was the drug dispensing error. So you captured the fact that there was an accidental overdose, even though the word overdose is not in the report, because according to MedDRA, an overdose is more than the maximum recommended dose. That captures the concept. It was unintentional, so you can select the qualifier accidental, right? And then you have the fact that the drug dispensing error occurred. So you are capturing everything that you received in the report with the selection of these two LLTs. I want to move on to a few more advanced principles and then maybe stop for questions. So let's talk about death and other patient outcomes. Now, typically death, disability, hospitalization, they're all outcomes. They're typically not reported as adverse events or adverse reactions. They're considered either outcomes with their own specific area to capture that outcome, or a series criteria. If the only information you receive is the death or the hospitalization, MedDRA does have LLTs to capture different types of death and the hospitalization. But if there's no additional information that's coming to you from the death, then there's no need to capture the death or the hospitalization, because typically they are outcomes. So what kind of scenarios would give you more clinical information with the death itself? Here's an example. The patient experienced a rash and had a sudden cardiac death. So they're not giving you the cause of death. They're just giving you a sign or symptom that happened and the type of death that occurred. A rash is not usually fatal, and the fact that the patient had a sudden cardiac death, that particular type of death gives you more clinical information. So this is an example of a scenario where you do want to capture the death as a separate LLT because it's giving you more clinical information. But if this was, for example, a severe myocardial infarction and the patient died, the fact that the patient died is supposed to be captured either as an outcome in its own field or as a series criteria in its own field. It's not intended to be the adverse event. The adverse event would be the severe myocardial infarction. So let's move on to another another few principles. But actually, I do want to stop here. I have a sense that there are questions waiting. Hannah, am I correct? Are there questions waiting?
We do have a few questions, yes.
Okay, let's tackle a couple before we move on so we don't have too many waiting. Go ahead.
All right, our first one reads, so in the case we have an investigation result and a diagnosis, we always prefer to code the diagnosis.
As long as the investigation result is in alignment and consistent with that diagnosis, the answer is yes, like the hyperkalemia with an elevated blood potassium level. But if you have an investigation and it's not consistent with your diagnosis, then you want to capture both.
Wonderful. Our next question asks, is it preferred to acquire more information to prevent split coding?
That's a very interesting question. I mean, it really depends on a few things. One of them is the data build specifications that are followed by your organization. So if your organization has an approach where it's a one-to-one correlation, then you really don't have the ability to select more than one LLT per reporter, and you may have to split the report. That's one consideration. The other consideration is, are you able to elicit more information? Because there are scenarios where you are receiving maybe post-market information, maybe you are retrieving some kind of data or information from social platforms online. You don't have the ability to track down the reporter and ask for more questions. Maybe that particular site has closed, if that investigational site has closed, and you're doing your analysis at the end, but they're already closed, so you can't send any more queries. So it really depends on your scenario. If you're able to elicit more information and you'd like to do that, you can. So for example, you received multiple signs and symptoms without a diagnosis. You'd rather query the site for a diagnosis before you split. Yes, of course you can do that. So that's one approach that you can discuss internally with your organization and decide what to do. The PTC guideline will tell you, if you're unable to reach more information, here's what we recommend you do. So the decision whether or not to query is really an organization approach, and whether it's possible for you or not. So I hope that helped you with that question. Anything else, Hannah? Maybe one or two more?
We've got two more actually, so that's perfect. Our next one says, are dispensing errors only at the HLT level?
That's another interesting question. So let me take you to the browser and answer that. So we said, here are the product dispensing errors. And just to make sure, Hannah, you are seeing the browser?
Yes.
All right, so let's open this up and see all the PTs. So here are the PTs under that HLT of product dispensing errors. HLT are grouping terms in MedDRA, so they are not used for coding. For coding, you use LLTs. And some LLTs, because they are the best representative of that concept, are themselves PTs, right? That's how MedDRA is built. MedDRA is built where every PT is actually duplicated at the LLT level, but it's intended to aggregate a group of sibling LLTs that really convey the same unique medical concept. So there are a group of PTs under every HLT. The number, of course, will differ. So there's no specific number of PTs per HLT, but here are your dispensing errors. So if you know that your product was a device and there was a dispensing error with the device, you can select a PT for device dispensing error. If it was not a device, here's your product dispensing issue and product dispensing error. If you know that what happened was an error, then you can choose the product dispensing error. If your story doesn't really tell you whether or not this was unintentional, and as you read through it, you're not sure if it represents a medication error, maybe it was a dispensing issue. So you can select the best LLT or PT that reflects your scenario. But no, it's not just at the HLT level. You had one more, Hannah?
Yes. Are dispensing errors at the healthcare professional level? Do they come from healthcare professionals?
So dispensing errors, yes, let me go back to here. So medication errors, all medication errors, they are errors that occurred during the cycle of medication use while the product was in the hands of the healthcare professional or the patient or the consumer. So that's the cycle of the medication use. And healthcare professional could be the physician, it could be the pharmacist, it could be the nurse. So any healthcare professional um, could be the one referenced in that. So in the product descriptions, in the concept descriptions, under medication errors, here, while, so here. So medication errors, all medication errors, the concept description defined them, like we said, unintentional, preventable, and they occurred while the medication is in the control of the healthcare professional, patient, or consumer. So the answer is yes. All right, so let's go back and finish off some of these concepts as well, some of these approaches for drug interactions. So interactions are reactions either between the drugs themselves, whether drugs and other drugs, or drug and food, drug and devices, alcohol, etc. If the reporter states clearly that an interaction occurred, you do want to select a MedDRA term that has interaction, that shows that interaction. And this is according to the PTC guideline. If the reporter did not specifically state that an interaction occurred, then you want to maybe avoid an inference that there was an interaction. There could be scenarios where you argue that you have the medical knowledge and you have enough context to back you up that there was an interaction, even though the reporter did not mention an interaction. Maybe you have, maybe you are the manufacturer of that product and you know what it interacts with. And based on the story that you received from the reporter, you can infer that there was an interaction that occurred and you can support that with contextual information. That's fine, but please, like we said, document, train, and ensure consistency. But according to the PTC guidelines, you do need to have an interaction called out in the report to use the LLTs available in MedDRA for interactions. Like the torsade de pointes with the suspected drug interaction, you have the interaction in the verbatim. So you're coding it as a drug interaction, even though it's suspected in the verbatim, but you're coding it as a drug interaction and you're coding the medical concept as well. Let's talk about suicide and self-harm. So in MedDRA, there are terms for suicide and there are terms for completed suicide. So a suicide attempt is not the same as a completed suicide. If your verbatim shows that the suicide attempt carried through to the unfortunate result of the death of that person, that's a completed suicide. So a completed suicide is only used when you have information in the report that an attempted suicide resulted in the death. And even if you have an overdose in your report, you cannot assume that that overdose was intentional. So you cannot map it or code it as a suicide attempt just because you have an intentional overdose. You need to be true to the source verbatim. Same with self-harm. So if a patient committed self-harm, but they don't mention suicide or suicide attempt, you code it to the closest matching LLT of self-injury terms in MedDRA. All right, let's practice some of the principles that we just mentioned, starting with this one. So if we have a death from cerebral hemorrhage, the pole is activated. Let's think back about what we talked about death. We said that death itself is an outcome, but death can be coded if it provides additional clinical information. So this is death from cerebral hemorrhage. Which LLT or LLTs would you select for this one? I think we have enough to show responses. I'm very happy to see that the majority have selected the cerebral hemorrhage, because that is the correct option here. In this particular scenario, they gave you the cause of death and they gave you death. But usually, in most cases, death has its own field to capture in your database. So you don't need to capture it when it's reported as death from cerebral hemorrhage. It doesn't give you any additional clinical information. You could come back and say, well, I'm collecting information online and this is useful for me. I don't have other specific fields for capturing death. That's fine. Document, train, and ensure consistency, right? But if you are using a typical approach and this is an adverse event and you are in a clinical setting and you have serious criteria, you have outcome fields that capture death, then you're not capturing anything additional here to code it as an adverse event. You code the underlying cause of death. What about this one? Patient was found dead. Let's activate the poll and see what folks think about this one. So in this particular report, the only thing you received was the patient was found dead. Which one of these LLTs do you think is the best match for your scenario? And I think I have enough counts. Let's check the responses. All right, so yes, the majority have picked correctly. Found dead is an LLT that is available in MedDRA, and all death terms in MedDRA are under the general system organ class. So found dead is an LLT available in MedDRA. It's the closest match to the verbatim that you received. Not that death is wrong, it's just not the closest LLT to the report that you've received. What about an interaction example? So this patient took an antihistamine and took her prescription proton pump inhibitor and developed vertigo. What do you guys think about this one? Now think back to what we said about interaction. According to the PTC guidelines, if interaction is mentioned in the verbatim, then you do need to select an LLT for interaction. So review your reports and make a decision, and let's see your responses. Okay, so I see many folks pick the vertigo, which is fine. And I see folks have picked the drug interaction. But why would you pick the drug interaction? The reporter is not telling you that an interaction occurred between the two drugs. They're telling you that she took an antihistamine and she took her prescription proton pump inhibitor. Many folks take multiple medications. That doesn't mean that just because they took them that they will interact. So unless you can support your rationale, then you don't code the drug interaction in this scenario, because you can't make the assumption that an interaction happened between the antihistamine and her prescription proton pump just because she took both of them. So if she took more than one product and developed a side effect, that side effect could have been to one or the other, but it doesn't mean that there was an interaction. So in this particular example, only the vertigo needs to be coded. Let's do another example. How about this one? They deliberately took an overdose. What do you guys think about coding for this particular example? They deliberately took an overdose. All right, I think this one is an easy one. Let's see the responses. Yes, it is a deliberate overdose. The report does not tell you that they intended to attempt suicide, so we don't want to capture the suicide attempt, right? Remember what we said per the PTC guidelines. We don't want to make the assumption that this was a suicide attempt, even though it was a deliberate overdose. All right, so let's start with some coding exercises now. Just like we said, every report you see, just ask yourself, what is the information that's being reported? How can I capture as many of these as I can? And are there combinations that help me in MedDRA? Are there any terms in MedDRA that are combination terms? And let's start with the first one. a man with a decreased fertility. What do you guys think about this one? What is the best option to capture the report that you received when you see man with decreased fertility? And Hannah, as we go through these exercises, if you get questions coming in while we're waiting for responses, please feel free to present the questions.
Okay, we do actually have a question waiting. It asks, if an event is reported but it is considered a positive, for example, weight gain, do you code weight gain and unexpected beneficial therapeutic response, or would you do only weight gain?
That's an interesting question. Now, depending on the population, the scenario, a weight gain is not necessarily a beneficial response, right? So that kind of decision needs to be discussed internally. It will depend on your product. It will depend on what profile you have already available to you as a safety profile of your product and your population and your organizational approach. So if you have a beneficial effect, it is of benefit to you to capture that, because you could eventually end up with additional indications for this product, as long as you know that you are assuming this benefit correctly. So like I said, a weight gain is not always necessarily a beneficial outcome, depending on how fast, how much, what kind of population your product was given to, and the scenarios surrounding it. But if you have a beneficial effect and you think that this is a beneficial effect and you can justify it, then it would be of benefit to you to capture that, because at the end of the day, you'll be analyzing that and you could end up with additional uses, additional indications for the product. But it does need an internal discussion. And again, document, train, be consistent in your approach. And in those kind of scenarios, when you have that kind of documentation, please provide it to your regulator when you submit your data. All right, so I have enough responses for this one. Let's check what people think about this one. Fertility decreased male. And why is this the correct answer? Because it captures all of the information you received in your report. It has the fact that there was decreased fertility, because that's what the report says. The report did not say infertile, but it says decreased fertility and specified that it was a man. So you do have the LLT that captures that gender. Now, genders is not always something available in MedDRA, depending on the concept, if gender is of significance, like for fertility or, for example, breast cancer. Let's do another one. And we'll go through maybe 10 or so of these and then stop at the end for more questions. So, but Hannah, please, if we have questions, do feel to present them as we're opening up these polls for responses. All right, so became colorblind in adolescence. So what do you guys think about this one? Which LLT would you think is the one that best reflects the report as you received it? Became colorblind in adolescence.
As people are responding, we do have another question. It asks, regarding a previous part of the session, when a procedure result does not provide too much information, for example, PET scan showed positive findings in pancreas, is it best to capture the procedure as abnormal or assume a disorder in the location provided?
I think you answered your own question. All your reporters said that there was something found in the pancreas, right? But you cannot assume a disorder because there's no diagnosis of what that result is, unless you have additional follow-up reports giving you the diagnosis. All right, so let's see the result here. All right, so color blindness acquired is correct. You guys found out here that the spelling in MedDRA can be in English and in British English and in American English at the LLT level. So if you have that distinction in your report, you can select the spelling that best matches it, and it is acquired because it happened in adolescence. Now, those of you who are curious about standalone color blindness. Standalone color blindness is a congenital condition because mostly it happens, is something you're born with. In MedDRA, the qualifier of acquired versus congenital is added for the less common concept. So color blindness, unqualified in MedDRA, would be a congenital condition. Acquired color blindness is what's being reported here. So it's important to use that LLT that is qualified as acquired. You guys are correct. What about this one? Turned very greasy. All right. So turned very greasy. What is the reporter telling you? How much information is the reporting giving you? And do you have enough to make an LLT selection here? All right. I do see responses came in, so let's check what people are thinking. Unevaluable event. And that is correct because you don't know what turned greasy. Was it the patient, part of the patient, their skin, their hair? Was it actually the product, the pill, the liquid? You don't know what turned greasy. So your best option here is unevaluable event. Very good. What about this one? Patient experienced a medical problem. Now you know that something is happening with the patient. They don't give you the details. You are unable to get more information from the reporter. What do you think about this one?
As responses come in, we do have another question. It asks, what if the report includes verbatim of a drug interaction, but there is no pharmacologic rationale to support a mechanism for drug interaction? Would you still code a drug interaction term?
So that really depends on a couple of things. One is, are you able to elicit more information? Two is, can you support your rationale? Can you support your rationale that there is no basis, there's no pharmacological basis for that interaction? So just because something is not documented in the report, right? So it really depends on your level of knowledge of the product, the rationale that you don't support this. Can you document that? Can you provide that to a regulator and support your rationale? Can you elicit more information from the reporter? Because you are not in agreement with the reporter. The first approach, if you can get more information, you do try to get more information and clarity. If the reporter insists on their report, then it's an internal discussion. Do you want to stay true to the reporter, right? And then maybe add an addendum with your rationale, or do you want to just not code the drug interaction and just code the sequelae? But according to the PTC guidelines, if the reporter gives you the report that a drug interaction occurred, you want to capture that drug interaction as one of your LLTs. If you're not in agreement with that and you can't elicit more clarity from the reporter, then have an internal discussion, document what you decided on, and make that documentation available to the regulator. All right, let's see responses here. So for this particular example, the patient experienced a medical problem. So it was clear that this is something to do with the patient. So an unevaluable event or unevaluable reaction would not work in this case. An unevaluable reaction assumes exposure, which is not intended here. So we have an ill-defined disorder. The best option here is an ill-defined disorder based on the PTC guideline. This is something that happened to the patient. I don't have enough information or details to select anything in terms of medical conditions. So my best approach is to select an LLT for ill-defined disorder. Let's move on to the next one. I think we have 10 minutes left, so we can do maybe a few more. What about this one? The 2-year-old accidentally took his mother's medication. What do you guys think of this one?
We had a follow-up question come in from the last example. It asked, does disorder imply more of a medical diagnosis?
A disorder implies that there's something that's happening medically with the patient. We don't have a diagnosis because we don't have details enough to tell us what is happening with the patient, but we know that something medically is happening with the patient. So that's why we choose an ill-defined disorder. In itself, it's not a diagnosis, but it's reflective of a medical condition happening with the patient, but no details are available. All right, let's see this one. Most of you are thinking this is an accidental drug intake by a child. Yes, the child is provided in the verbatim. The fact that it was accidental is also provided in the verbatim. And the fact that it's a drug is provided in the verbatim. So not to say that these LLTs, the rest of them are all wrong. It's just that what is the closest LLT to the verbatim? So I'm very happy to see that you guys picked the correct one. If the verbatim did not specify that this was a medication, then maybe you can use product, right? All right, let's do another one. Infection after surgery. What do you guys think of this one? And I'm going to start showing the responses maybe a bit earlier so that we can do as many of these as we can. It is a post-op infection. There is no mention of the word wound in the report, so this is not necessarily a wound infection. This could be anything post-op infection process. Very good. So this is the correct answer. Very happy to see that. What about this one? He sold his father's medication. He sold his father's medication. One hint here is that concept descriptions do define drug diversion. So if you have access to your browser, you want to look up the concept description of what drug diversion is. But what do you guys think about this one? So he sold his father's medication. That's all the reporter is telling us. Let's see what most folks are thinking about. All right, so the correct answer is drug diversion. I'm very happy to see that. The reason why it's not intentional drug misuse, in the concept description, misuse is an intentional approach of using a therapeutic product for therapeutic purposes, but somewhere different than what's recommended, right? So we don't know why he sold his father's medication. It may not have been for a therapeutic purpose. So this is not really a misuse because the report does not tell us what happened with that medication. All we know is that he sold his father's medication. This is drug diversion. And maybe this is worthwhile showing the concept description for this one. So let's go into the concept descriptions. And let's find drug diversion. So drug diversion means that a drug is diverted from legal and medically necessary uses toward illegal use. Selling somebody else's prescription is an illegal use of that medication. Misuse, and let's just go to misuse and see it again. Misuse is the intentional use for a therapeutic purpose. And this is either by a patient or a consumer of a product other than as prescribed or not in accordance with the product information. So for that particular example, this was a drug diversion. All right, let's do another. Patient had MI. What do you guys think about this one? All right, so I have enough responses. And yes, unevaluable event is the correct one because MI is a non-current LLT in MedDRA. It can't be used for coding because it's an ambiguous abbreviation. It could be mitral incompetence, myocardial infarction, or others. All right. How about this one? Hypernatremia with a serum sodium of 115 milliequivalent per liter. What do you guys think about this one? All right, let's see what most folks are thinking. Yes, serum sodium abnormal, because this is a conflicting report. They gave us a hypernatremia with a serum sodium that is not consistent with a hypernatremia because this is below the average of serum sodium in the blood. So yes, I'm happy to see that. What about this one? She accidentally missed her morning dose. She accidentally missed her morning dose. What do you guys think of this one? And let's see responses. So yes, she missed her dose, but the report specifically says it was accidental. So even though the word accidentally missed dose is not offered as an LT here, but we have missed dose in error, which conveys the same concept. So the missed dose in error would be more specific to the report that is being received. All right. What about this one? So there's a story here that the doctor made an error while prescribing the medication. The pharmacist noticed the error and did not dispense the drug. So the wrong drug, never made it to the patient. And this is an important concept in the PTC guidelines. The fact that the wrong drug never made it to the patient means that it was intercepted at some point. So let's see the correct response. This was an intercepted drug prescribing error. Now, the rule is that if there was an interception, the type of medication error that was intercepted is the one as it occurred, the error as it occurred, not the stage at which it was intercepted. So the error occurred during the prescribing phase of the medication use cycle. But this was a drug prescribing error which eventually got intercepted. The wrong error never made it to the patient. So there was no intercepted drug dispensing error because the stage where the medication error occurred was the prescribing phase. So there was no drug dispensing error that was intercepted. It was a drug prescribing error that was intercepted. All right. What about this one? And maybe this will be our last one. So the patient reported a loss of smell and thought she might have a COVID-19 infection. So this takes us back to the first principle we talked about. She thought she might have a COVID-19 infection. And let's see the responses. Yes, this is very nice. You guys have it correctly. There is a suspected COVID diagnosis with a sign and symptom of loss of smell. So we capture both of them. This is very nice. And of course, the anosmia is the same as loss of smell, but the loss of smell matches the verbatim. All right, so let's wrap up with some coding pearls. MedDRA can be used not just for adverse events, it can be used for indications, medical history, surgeries, investigations, social circumstances. So it has a wide scope of application. And of course, when you're coding in MedDRA, you first look at the reporter's actual words. Can you use some of them, even if it's part of the word, not the full word? Because MedDRA is specific. It has a lot of detailed LLTs. And if you're not sure if you have the best LLT, you can right click and go to browser and look at surrounding LLTs and surrounding PTs. Don't forget the hierarchy to make sure you're in the right system organ class. You can also do the top-down approach, especially for things like medication error, where you start with the grouping term and go down. You can use medical resources, either online searches, medical dictionaries, colleagues, to help you identify whether signs and symptoms or results are a match to your diagnosis. In our basics of coding, we talk about Boolean search terms, like if you have a specific word that the concept starts with or contains or doesn't contain. These are things you can leverage in MedDRA, and of course the use of concept descriptions and more training. So we went over the advanced principles in the PTC guidance. We talked about concept descriptions. We had a lot of examples of coding and polling activities, and we ended up with these MedDRA pearls. These are our contacts. If you are interested in accessing the different browsers, you can always send us questions after this webinar to our help desk. And of course, check the training schedule for more offered trainings. I can stay on for a little bit, Hannah, if we have a lot of questions. I do realize some folks will need to drop off. We're at the top of the hour. We did address many questions throughout the webinar, but I'm happy to stay on for more.
Our first question asks if you could re-explain off-label use.
Off-label use. Okay, so let's go back to how it's described. Let's go with the O. And here is off-label use. Now, this is for the purposes of coding to MedDRA. Off-label use is a situation where you have a healthcare professional taking an intentional step of either prescribing a medication, dispensing a medication, recommending a medication that is not in accordance with the authorized product information. So they may have used a medication for a different indication than authorized, or for a different population than authorized, a different dose, a different frequency, a different route. But they are accepted medical approaches as off-label uses for this particular product. Now, if you want to code off-label use, the original approach by the PTC guideline was you have to have the reporter specifically mention that this was an off-label use. However, there was a lot of question and pushback coming in from MedDRA users saying that we know this was an off-label use in this particular report, but the reporter didn't use the actual words off-label use. We need somehow to code something where we have medical knowledge that supports the fact that this was an off-label use, but the words off-label are not in the report. And that's when they agreed to add suspected off-label use to MedDRA. So I hope that I answered that question, but if still you have further questions, please revert back.
Our next question asks, in cases where the symptoms reported by the patient are coded in the initial report and a possible diagnosis from a physician is later received, should we retain both the patient-reported reactions and the physician's diagnosis?
So this goes again to your specific database setup. Like there are certain protocols where if you have a diagnosis later on, then you change that to the diagnosis, and it traces back historically to the first onset date. But certain organizations will tell you you'll have an end date to your signs and symptoms and a new onset date for the diagnosis. So we can't answer those kind of questions for you. They're really dependent on organizational approach. Again, you document, you train, you're consistent in your review with your quality assurance. But in terms of the same report having both, we offered you the PTC guidelines. If the report changes between, historically over time, that depends on your organizational approach.
Our next question asks if you could please clarify more about when to use event versus unevaluable reaction.
Well, the word reaction itself, when you think about an adverse reaction versus an adverse event, an adverse reaction is really temporally associated with the administration of a product or an exposure to a product. An adverse event could have happened even before the administration of the first dose in trial settings. So in trial settings, you have an adverse event, and the adverse event could have occurred as soon as the patient, signed the informed consent, even before exposure to the product. An adverse reaction infers that there was exposure that is temporally associated with the product. So the event was temporally associated with the product. So when you want to pick unevaluable reaction, think about a scenario where the patient received the product and then developed a reaction, or the product was administered and then something turned green, but you don't know if that something turned green was the patient or the product itself. So think of the word reaction with the temporal qualifier. Any other questions,
Yes, our
Hannah?
next question asks, is it okay to use issue terms when the verbatim does not allow to determine if an action was intentional, off-label use / misuse, or non-intentional medication error?
Yes, that is correct. So your question is correct. There are issue terms available in MedDRA and error terms available in MedDRA for similar sounding scenarios for that particular case when you're not sure if it was done intentionally or not. Yes, you can use issue.
Wonderful. Our next question has, would you please clarify the use of adverse event NOS and unevaluable event?
Well, the NOS is just not otherwise specified, and it's only available at the LLT level. But I want to show you in the, let's just go to the browser. If we put adverse event, right, and we right click it and we go to browser, this HLT of therapeutic and non-therapeutic responses has a few different options that you can select from depending on your scenario. So you have adverse event, and adverse event has LLTs under it like adverse event NOS. If your verbatim specifically says no other information is available, for example, or not otherwise specified, and you want to match the LLT. Your adverse reaction, again, it infers that there is a temporal relationship here occurring. So adverse event and adverse reaction are under the same HLT, in addition to other examples like, I'm going to give you drug ineffective is also under that same HLT. Product ineffective is also under that same HLT. So you have a lot of examples in that HLT for your particular scenario. But adverse event, NOS, only means it's an adverse event, but there was no additional information in the reported verbatim. So the reported verbatim gave you that there was an adverse event, but there was no additional details. So the NOS is not available at the PT level. It's only at the LLT level if you have something in your verbatim that supports the use of that acronym. But like we said, adverse event and adverse reaction really depends on whether or not you have contextual information to support the temporal relationship. Any other questions?
I think this is our last question. It asks, could you explain under which circumstance do we use the LLT needle track marks? Is it right to use it with drug device products administered or via subcutaneous, excuse me?
I'm not sure I can answer that one really, because it really depends on your product, your use of the product, and how you have been coding previous terms like that in your safety profile. So it really depends on the internal discussion for that particular example. Any other questions, Hannah?
Wonderful. It looks like that was it.
All right, wonderful. Well, I do thank you all for staying over. We went over a few minutes from the allotted time, but thank you for joining us today. I hope you found it useful, and we look forward to seeing you in future webinars. Have a great rest of your day.